Thank you. This is a procedure where there are 5 million cases a year. First time, most 17 to 21-year-olds are exposed to opioids. And most of the data I'm going to show you is 10 to 30 years old. So what I'm going to show you is actually old news, not new news. Okay, how do I make this advance here? Okay, got it. These are my disclosures here. And again, just like all of you, the grant checks aren't written to Elliot V. Hersh. They're written to the trustees of the University of Pennsylvania. This is the surgery. It's like having a size 28 mouth and 32 teeth. That's why it's done. The teeth partially erupt. They become painful. The area is constantly getting infected. They can cause orthodontic problems. They push on the other teeth. They become cystic. Often they're just removed prophylactically to avoid these problems. It's more like an orthopedic procedure. There's soft tissue trauma, there's bony trauma. You can see the tooth is sectioned, the bone is sectioned. You sew them up, it doesn't look like much of a big deal, but very, very predictably, 1 to 3 hours after surgery, once the local anesthesia has worn off, 95% or more of these patients have pain of a moderate to severe intensity. Yeah, this is a joke, okay? My former dean did not like this. He was an oral surgeon. This type of pain is mainly driven by inflammation. That's why the NSAIDs work so well in this pain. Prostaglandins are a key component. They're generated from damaged cell membranes. They sensitize free nerve endings to other mediators of pain. This is old data that was adopted from the McGill Pain Questionnaire. And I just want to impress you with that these people short-term really, really hurt, that their total pain relief indexes are actually higher than some of these real nasty chronic pain syndromes. But typically heals in 3 to 5 days and the pain goes away. It rarely becomes chronic. When we do these studies, I don't have to go over this with this group. We use good clinical trial technique. FDA is now demanding multi-dose studies. In the past, we could get away doing single-dose studies, but they want a better handle on side effects with multi-dose studies. But single-dose studies can really show you a lot of the things about these drugs. Again, very old data. Aspirin and acetaminophen, they're equianalgesic in this model. Yes, acetaminophen doesn't have a lot of anti-inflammatory effects, but it's good at downregulating the upregulation of central cyclooxygenase that's induced by this type of surgery. You can get a little bit more of a dose response by upping the doses to 1,000 milligrams. Aspirin's come out of vogue as far as post-surgical dental pain and other types of pain because of its pronounced antiplatelet effects. And now we're all aware that we better be careful on our dosing with acetaminophen. And McNeil, now J&J Consumer, has been proactive with this. And on all their Tylenol products, they recommend no more than 3,000 milligrams a day, actually more conservative than the FDA guidelines of 4 grams a day. By the way, if you get addicted or you're misusing immediate release opioids, the other danger is not only overdosing with the opioid, but also blowing out your liver with the acetaminophen component. I'm not going to spend a lot of time on this, but it's a buildup of this hepatotoxic metabolite N-acetyl paraquinonamine with an overdose of acetaminophen, shifting the metabolic pathway away from glucuronidation to the cytochrome P450 system. This is a whole study. Do these opioid combinations work in post-surgical dental pain? Yes, they do. You can see that this is essentially the top curve is 2 Tylenol number 3s, and you get this additive analgesic effect. Notice, though, that the pure opioid by itself, 60 of codeine, about 10 of hydrocodone, 5 of oxycodone, is inferior to acetaminophen 600 in this pain model. By the way, how do people mostly prescribe these drugs? Take 1 or 2 as needed? Well, 1 T3, which is equivalent to 1 Vicodin, is inferior to 2 over-the-counter acetaminophen. Hey, you could go to the big guns. Oxycodone by itself in this pain model, no better than 1 extra strength Tylenol. You combine them, you get an additive analgesic effect. I haven't spoken about side effects yet. This is the side effect profile of just a single dose of these agents in this study. And clearly in the oxycodone group, even from the first dose during a 4-hour observation period, all the classic opioid side effects, acute side effects are appearing other than constipation. If we dose them for a day or 2, that would appear also. Kind of interesting thing here, you see a couple of headaches in each of these groups showing up. Well, if you just had 3 or 4 bony impacted third molars surgically ripped out of your head, you might complain of a headache. It's probably a procedural related event. I don't think, in my mind, one opioid is better than another. I think it's a numbers game. It's based on potency, and oxycodone, that's the Jack Daniels. Hydrocodone's the red wine. Codeine and tramadol, they're the Budweisers. Propoxyphene, which was even weaker, is now off the market because of cardiotoxic events. Tramadol, but this is not it's still only DEA Schedule 4. This is a scourge now in Africa, in continental Africa, as far as abuse. But in post-surgical dental pain, it's minimally 100 milligrams by itself. It's minimally better than placebo, and is destroyed by a non-steroidal anti-inflammatory drug. The other issues with tramadol and codeine, by the way, is these metabolic nuances. You have some people that are so-called normal metabolizers. You've got slow metabolizers, high metabolizers. Codeine's totally a prodrug. Tramadol's partially a prodrug. So you get some people that don't demethylate it. They get an inferior analgesic response. They demethylate it too much. They form too much morphine, and then they get too many opioid-induced side effects. And then to make life even more complex, there are common drugs that people are taking that can interact with the cytochrome P450 2D6 iso enzyme. American Academy of Pediatrics and the FDA now have black box warnings on, don't use codeine, in kids, and similar warnings are there for tramadol because they're worried about these hypermetabolizers forming too much of the active metabolite. I don't have to, spend a lot of time with this group about the acute side effects of opioids. One of the ways we found to kind of limit nausea and vomiting is to limit ambulation on the first 2 doses. Constipation kicks in like 2 days in this opioid naive individual, and it can be so good or so bad that your patient, can go into the construction business. Tolerance, physical dependence, psychological dependence. You all know what those issues are. And then we get into this, and this isn't just the Duke dentist. This could be the Duke physician, the Duke nurse practitioner. It's always their Percocets of Vicodins going down the toilet or the sink. It's never their antibiotics or their lipid-lowering drugs. This is a study published in New England Journal of Medicine, looking at 20,000 12th graders. What did they like to experiment with? Well, between the years of 2001 and 2005, 10 to 12% said that they were experimenting with Vicodin. And the reason I bring this up is that often was our go-to drug. Okay, up until 2012, dentists, mainly oral surgeons, 60 to 70% of the scripts are oral and maxillofacial surgeons. We were the number 2 immediate release opioid prescribers. We're now down to 6 or 7. I'd like to think it's me, but it's not just me, me pontificating. Some other interesting stuff that recently came out in the New England Journal of Medicine is, you're abusing prescription opioids, your risk of transitioning to injectable heroin is the highest among all gateway drugs. But it's kind of interesting, cocaine shows up. Some of the people like to do the balancing act with coke. They get overstimulated with coke, so they balance it with a CNS depressant, alcohol, a benzo, or an opioid. And those people that say that there's no risk of pot, leading to transition to heroin, the study doesn't support it. It's much lower than prescription opioids, but there seems to be some increased risk. And again, certainly the oral opioids, oxycodone, hydrocodone, they look a lot like heroin. So it's not surprising that transition occurs. So now I want to shift to these non-steroidal anti-inflammatory drugs. Some of these drugs have such a good safety profile that they're available over the counter. That's good and bad. It's good because it's easily accessible to your patients. It's bad because a lot of patients think they don't work. They're not strong. They're available over the counter. But I'm going to show you that, in fact, they do work. If I was going to show you any slide, this is the one I would show you. This is a single dose study. Again, look when this was published. This is old news, okay? Ibuprofen 400, at least as good, with more staying power than 2 Emperor number 3s, which is equivalent to 2 Vicodin. Codeine 60 by itself, miserable. Now, this is kind of shocking to some people. It's not shocking to me because the pain is driven by inflammation. This is placebo. This curve here is 60 milligrams of immediate release morphine. This thing on top is 2 Advil, 400 milligrams of ibuprofen. Why in this pain model does it work so well? This pain is mainly driven by inflammation. This is not sickle cell crisis. This is not breakthrough pancreatic cancer pain. New formulations of NSAIDs, you can get some better properties. You've all seen this drug on the market, Advil liquid gels. In fact, my biggest claim to fame is I did the study that promotes the commercial that for tough pain, nothing lasts longer or stronger than Advil liquid gels, not even extra strength Tylenol. In fact, there was a guy, I said this to this other presenter at a Board of Overseers meeting. I said, that's my claim to fame. And I said, what's yours? He said, he's sending up weather balloons from the Antarctic to study the origin of the cosmos. It's kind of interesting. He's studying the origin of the cosmos, and I'm comparing Advil liquid gels to extra strength Tylenol. Here we had to use a double-blind, double-dummy technique. Obviously, you'd have to be blind and dumb not to know when you got a liquid gel and when you got an acetaminophen caplet. But clearly, the liquid gel formulations really work well in this type of pain. And again, the problem with acetaminophen in this type of pain is if you multi-dose, it would be easy to exceed maximum daily doses. If we look at global evaluations in this study, when you get up to 400 milligrams of ibuprofen liquid gel, we have 96% of the patients rating the drug good, very good, or excellent. Acetaminophen 1,000, only about 72%. Now, this is an interesting group. The placebo group, 25% said it was good, very good, or excellent in this pain model. And we're looking into these people. Another thing, like how quickly do people need rescue drug? Do they need the Vicodin or the Percocet? Well, you can see with 400 of ibuprofen liquid gel, at 3 hours, we had only 1 out of 94 people bail out of the study. And at 6 hours, we only had a 17% dropout rate. So 83% were still in the study. The orange curve is actually 2 extra strength Excedrin. Caffeine is kind of interesting. It's an analgesic adjuvant. It seems to enhance the analgesic effects of aspirin, acetaminophen, and ibuprofen. We know it increases the absorption of weak acids. We know that caffeine is an adenosine receptor blocker, so that might have something to do with the analgesic enhancement effects. Looking at the side effect profile of the single dose study, what don't you see a lot of? You don't see the nausea, you don't see the dizziness, you don't see the drowsiness. Yes, you do see the headache. By the way, a little less with extra strength Excedrin could be why it's such a good headache drug. Preemptive strikes. This was done by Ray Dione. Ray used to run the anesthesia and analgesia branch at the National Institute of Dental and Craniofacial Research. Basically, the study design was give a dose of an NSAID 30 minutes before surgery and then give a second dose 4 hours after surgery. Now you're going to be measuring pain intensity, so the lower the curve, the better, and preemptive strikes with fluorbiprofen followed by a postoperative strike produce much lower pain intensity scores than a preemptive strike with 2 Percocets followed by a postoperative strike of 2 Percocets. Just a couple of other NSAIDs, naproxen sodium, it works well in this pain model. Its advantage is that it's got a longer duration of action. It's not quite as kind to the tummy as ibuprofen, certainly more ulcerogenic when used chronically, but we're talking typically about 3 to 5 days use in these patients. Another drug, hey, I don't want that naproxen or that ibuprofen. It's available over the counter. Prescribe an NSAID they don't know about. So this is actually almost a liquid gel formulation of diclofenac. This is actually the #1 NSAID prescribed around the world. And you could see that 25, 50, 100 milligrams of this Zipsor formulation, certainly a lot better than placebo. If you go ahead and look at global evaluations, you have anywhere from 68 to 94% rating the drug good, very good, or excellent. Unfortunately, the maximum dose of this formulation daily is 100 milligrams, and you're supposed to take 25 every 6 hours. So my recommendation is a little off-label. Hit them with 50 on the first dose and then back down to 25. Combining ibuprofen plus acetaminophen, this really works in this type of pain. Ibuprofen 200 plus acetaminophen 500, at least as good as ibuprofen 400 plus almost the amount of codeine in a Tylenol #3, superior to 1,000 of acetaminophen plus 30 of codeine. I don't like the ibuprofen 400 plus acetaminophen 1,000 because remember, these are average curves, and buried in this top curve that looks so great are maybe 5 or 6 people who needed rescue med in 4 or 5 hours, and they would then take super therapeutic doses of acetaminophen. So Paul Moore and I have backed down to ibuprofen 400 plus acetaminophen 500. So these drugs work, they're well tolerated. Again, we're using them short term. So yes, the prostaglandin man says that prostaglandins are involved in pain and inflammation, but they also have normal constitutive roles. Certainly somebody that has a history of GI ulcers, I'm not giving them one Advil. Somebody, there's some issue in people on certain blood pressure drugs when you take these drugs for more than 5 days. Okay. This is the limitation of NSAID analgesics. There are maybe in this pain model 15 to 20% of people that actually need a short course of an opioid. And we're trying to identify who they are, and I can get into that in the discussion section. And there are some specific contraindications. By the way, some people don't know about this. Physicians and dentists hey, they're on lithium. Maybe you shouldn't put them on Aleve because it jacks up the blood levels and you end up with classic lithium toxicity. This is an old study. What Sharon Gordon and Ray Dione, what's kind of interesting? Ray Dione's slides got better when he married Sharon Gordon, who's now dean at University of Connecticut, so I know what was going on in that dog and pony show. But what they were able to show was if you gave patients after surgery a long-acting local anesthetic, Marcaine, bupivacaine with 1 to 200,000, post-surgery, regardless of what you gave them pre-surgery, and these are GA cases, that these patients not only had less pain during the immediate 0 to 4 hours, but they had less pain at 48 hours, and they're not numb anymore. You're probably preventing central sensitization. Meta-analysis data clearly shows that in this type of pain, the NSAIDs work. If you look at numbers needed to treat, look at the ibuprofen and diclofenac data versus the acetaminophen plus codeine data, we're talking about numbers needed to treat with ibuprofen or diclofenac in the 2 to 2.5 range, where with the opioid combination drugs, you're talking about somewhere between 3 to 5 if you dose them optimally, 4 to 10 if you suboptimally dose them like most people do. This is the flexible analgesic guidelines that Paul Moore and I have kind of come up with. The one thing I want you to take home with you is that once we get beyond mild pain, we're talking about dosing at in a fixed interval for 24 to 48 hours. The other thing I want to bring up to you is oral surgeons do have a dilemma. They are prescribing these drugs when the patients are still numb. They have no clue how much pain these patients are going to have. So these drugs work, they're safe. Pre-emptive strikes with NSAIDs and using long-acting local anesthetics at the end of the procedure seem to have a beneficial effect, reducing opioid requirements. Combining an NSAID with acetaminophen appears to have also an opioid sparing effect. And in this type of pain, not sickle cell, not breakthrough cancer pain, the non-steroidal anti-inflammatory drugs are first line. Final 2 slides, 30 seconds. Before I knew anything about pharmacology, after I studied it. Okay, thank you for allowing me to go a minute over.